Alrighty, so today's topic will be a bit different than what is typically discussed in this journal club. My presentation today will not be about a case report or a clinical study. Instead, I will be discussing a topic related to healthcare policy and legislation. As medical students and physicians, it is extremely important to remain educated on relevant topics in healthcare policy and to stay involved with local and national healthcare advocacy efforts. While clinical research is critical to advancing our collective understanding of human health, policy is an equally powerful tool in bettering the lives of our patients and should be pursued with equal rigor and enthusiasm. So with that said, I'm happy to present today on the topic of pharmacy benefit managers. So all the information in my presentation today comes from an article I authored for the American Medical Association Committee on Legislation and Advocacy. The article was written for medical students and physicians in order to provide some relevant information regarding PBMs and to summarize the legislative efforts surrounding them. In this presentation, I'm going to explain what a PBM is, their history, how they operate, why they're controversial, and some legislative reforms targeting their business practices. So what is a pharmacy benefit manager? Basically, PBMs are middlemen between the insurance companies and drug manufacturers. Insurance companies provide their customers with two major benefits, the first being healthcare coverage and the second being prescription drug coverage. PBMs are hired by insurance companies to coordinate all aspects of the prescription drug side of that equation. The process of managing drug benefits is quite cumbersome and involves a complicated relationship between drug manufacturers, drug distributors, pharmacies, insurance companies, and patients. So PBMs exist to handle all the logistics required or related to acquiring the drugs, dispensing them, and then paying pharmacies for those drugs. Most notably, PBMs are responsible for establishing the drug formulary, which is the list of medications that your plan will pay for. Not only that, but the largest PBMs also own and operate a network of pharmacies. So this is just a brief history of PBMs, kind of how they emerged in the US. So the first PBM was founded in 1958, and that was in Canada. It wasn't until the mid to late 60s that PBMs found their way into the United States market. This really exploded in 1974 after the passing of the ERISA Act. So this act essentially established some federal guidelines for employment-based healthcare plans. And so insurance companies began hiring PBMs to coordinate their drug benefits in order to be compliant with this bill. So then over the next few decades here, we have some horizontal and vertical integration. You see drug companies, insurance companies, and wholesalers starting to buy up all the PBMs. You see a lot of trading of these companies until about uh, early 2000s, they start to consolidate into what they look like today. So as early as 2018, CVS acquired Aetna, and Cigna merged with their PBM Express Scripts. So these companies have been changing hands a lot until recently, where they've consolidated until what I like to call the big three. So these three conglomerates here, CVS, United Healthcare, and Cigna, own the three major PBMs in the United States. Together, these companies control about 79% of all prescription drug claims. And what I'm really trying to point out with this slide here is that each of these healthcare companies, they all own their own insurance company, listed here on the top, their own pharmacy network, listed here in the middle, and then their own PBMs, which are down here. So CVS, their pharmacies are the retail pharmacies that you're familiar with, but United's OptumRx pharmacies are mail order, along with Cigna's Express Scripts pharmacy. And so these three companies control the vast majority of all drug claims and don't really compete with anybody else for prescription drugs. Another thing I just wanted to touch on, just because it's going to become important later in this presentation, are the drug formularies. So these formularies are divided into various tiers, in which drugs up here in the top tier have the lowest copay. They're offered to customers at the lowest price, while drugs on the lowest tiers have the highest copay. As lower drug prices tend to increase drug sales, pharmacy companies or pharmaceutical companies are incentivized to get their drugs into the top tier of this formulary. And this is going to become important in a few minutes when we're talking about rebates. So this is kind of the meat and potatoes of the presentation. I want to start talking about how these companies specifically make their money. So as you can see on the slide here, there's only two major revenue streams. We have rebates and administrative fees. So administrative fees are relatively straightforward. They're paid by insurance companies to the PBMs in return for their services. Rebates are the major method by which these companies derive income. And rebates are relatively difficult to explain, so I'm going to do my best to describe how a rebate works in this context. So simply, rebates are discounts that PBMs negotiate with drug manufacturers. This rebate is paid to the PBM by the drug manufacturer retroactively following the sale. These rebates are then returned to the insurance company with a percentage withheld by the PBM as payment for its services. And I understand that's a bit complicated, so I've made this graphic to explain and simplify this concept. And so just to kind of orient you to what's going on here, each one of these shapes represents a different player in the prescription drug industry. We have the patient, the drug manufacturers, the distributors, the pharmacies, the plan sponsor or your employer, and the health insurance plan itself. Above all of these is the PBM, which is kind of coordinating between them all. So the blue arrows here represent cash flow. The orange arrows represent co-payments, and the green arrows represent the flow of drugs. And so I'm going to walk you through an example scenario here to show you where the rebates are coming from. So a patient wants to go get prescription drug coverage. So they pay their premiums to their health plan every month. That's where this arrow is coming from. The plan sponsor is also paying the health plan. Okay, so now the patient wants to go and buy a prescription. Let's say they're going to buy metformin. So they go to the retail pharmacy and they pay their copay, which is, let's call it $1. So the patient pays $1 to the pharmacy, and then $1 goes back to the PBM because the PBM sets copays. All right, now it's time for the PBM to purchase that order of metformin from the pharmacy. So the PBM is going to pay $10 for that drug. We're going to call the list price of metformin $10. That's what the drug manufacturer says it's worth. So with that $10, the pharmacy will buy it from the distributor who buys it from the drug manufacturer for $10. So after the drug manufacturer gets an order from this PBM, they will then return a set amount of money to the PBM as a discount. We're going to call that 10%. So the PBM buys it from the drug manufacturer for $10. The drug manufacturer returns $1 to the PBM. The PBM then returns most of that money to the health insurance plan, which is effectively a discount for the insurance plan. They retain a small portion of that money as payment for their services. So rebates are extremely important, and they also play a role in the development of the drug formularies, which I mentioned earlier. So drug formularies are established based on a variety of factors, including drug safety, efficacy, and availability, but rebate payments also play a major role in determining on which drug or on which tier a drug will be placed. PBMs often negotiate rebates from drug manufacturers in exchange for preferred placement on the drug formulary. In theory, rebates are a win-win for PBMs and drug consumers. PBMs can profit for their services, and consumers get to enjoy lower drug prices. Unfortunately, this pricing model is flawed and has led to higher drug prices overall. As drug manufacturers compete for preferred formulary placement, rebate payments to PBMs have steadily increased. To maintain profitability, drug manufacturers are forced to increase the list price of the drug just to maintain safe profit margins. One 2020 study suggests that for every dollar increase in rebate payments, list prices of the drug increase by $1.17. Simply put, drug manufacturers artificially inflate drug prices so they can negotiate higher rebate payments with PBMs. All right, so let's talk about some of the concerning business practices that are being targeted by legislation. So these four terms are the ones you will see referenced in legislation and in articles online about these companies. So I'll start with the most obvious, the vertical integration. These companies control everything from the insurance plan, the formulary, and the pharmacy that dispenses the drugs, ensuring that they have essentially no market competition. This has allowed these companies to get away with the next three topics: steering, spread pricing, and gag orders. So steering is the practice of encouraging patients to use exclusively in-network pharmacies. And as you may have guessed, the pharmacies that are permitted into the network are those owned by the same corporate entity. If a patient were to fill their prescription at a pharmacy that has not been permitted into the network, they risk paying higher prices for the same drug. Independently owned pharmacies are often required to pay fees or accept lower reimbursements for drugs to be permitted into the network. This significantly decreases options available to patients and eliminates the need for competitive pricing. All right, spread pricing is when a PBM charges the insurance plan more money than it costs to buy a drug from a pharmacy. And this is different from a rebate, but kind of sounds the same. I'll give you an example to clarify how this works. So if a particular drug costs $10 at a pharmacy, the PBM will then charge the insurance company $20 for the same drug, keeping that extra $10 profit for themselves. And finally, gag orders. These are rules which forbid pharmacies from informing a patient if their medication would be cheaper as a cash transaction rather than billing insurance. So if the cash price is less than the copay, pharmacies were permitted to make that known to the patient. And how does this harm patients? Well, the increased rebate payments have led to increased list prices of drugs, as I mentioned. And this is especially bad for uninsured patients or patients who have not met their deductible, who are paying higher prices for drugs that would have been cheaper otherwise. Limited pharmacy options. Patients cannot go to a preferred pharmacy. Instead, they are forced to use either mail order pharmacies or local pharmacies that are controlled by their insurance plan, which limits competition. And finally, this limits the drugs that are available to patients. And often drug formularies will change year to year, which makes one drug available one year, but it'll be off the formulary the next year, forcing patients to switch off of drugs that they've been stable on for years. All right, so what has been passed already? So these are all laws that are on the books, that are passed currently. So the two at the top are the ones that I want to draw your attention to: the Know the Lowest Price Act and the Patient Right to Know Drug Prices Act. These two laws federally ban the practice of gag orders. So in 2018, both these laws were passed. One of them prohibits gag orders for PBMs operating Medicare plans, and the other bans gag orders for PBMs operating on all private insurance. So this effectively banned gag orders in the United States. So this was a huge step forward. Additionally, you'll see that there are gag clause bans in 44 states. Hold on. Okay, in 27 states, there are laws that prohibit pharmacy discrimination. And so these laws, there's a variety of them, and they all use different language, but the idea is to level the playing field between in-network and out-of-network pharmacies. Additionally, 13 states have laws preventing spread pricing, and 23 states require PBMs to report information annually to state institutions. So clearly there are a lot of states which have very limited legislation, and so there are some laws on the books, some laws that have been introduced to Congress that aim to control PBMs on a federal level. And so I'm going to go through these 6 laws here, these 6 bills, and kind of summarize them and point out some similarities between them, because these laws will likely be, in some form, the final legislation on PBMs. So this first one, PBM Reform Act. So this bill was introduced in 2023 and is still being reviewed by committees in Congress. This would require PBMs to report certain information annually to the plan sponsor, including the amount of co-payment assistance received from drug manufacturers and the total money spent by the health plan on prescription drugs. Additionally, this bill would prohibit the practice of spread pricing federally, and it would require PBMs to pass on all rebates or other services or other savings back to the insurance sponsor. And so this is the concept of rebate pass-through, and it comes up a lot in these laws. So the idea is that instead of retaining a portion of the rebate, the PBM would be forced to pass on 100% of the rebate to the insurance plan. All right, next we have the Healthcare Price Transparency Act. So this bill would also prohibit the practice of spread pricing and would prevent PBMs from decreasing payments to pharmacies to offset changes to federal health plans. It would also require PBMs to report information to the FTC regarding money received from insurance plans and paid to pharmacies. So here is another theme that is going to keep coming up over and over again in these proposed laws: the idea of transparency. These companies report very little public information. And so by increasing transparency, legislators and regulators would be able to better understand what is going on behind the doors of these companies. All right, so next, the Pharmacy Benefit Manager Transparency Act of 2023. So this also focuses on transparency. It would require PBMs to submit annual machine-readable reports to plan sponsors covering co-payment assistance, drug details, spending, and more. Additionally, this bill would order the Government Accountability Office to conduct a study to be released in 3 years, which would examine whether pharmacy networks integrated with health insurance plans are engaging in steering, and also would examine their reimbursement rates and other business practices. So another law targeting transparency. Next, we have the Ensuring PBM Competition Act. So this bill would prohibit any PBM participating in Medicare from owning a pharmacy. It would give PBMs 5 years to divest any of their pharmacy ownership. The Drug Act, the Delinking Revenue from Unfair Gouging Act, would prohibit steering, prohibits spread pricing, and proposes a flat rate fee for drugs rather than negotiating based on sales percentage. So it would effectively eliminate rebates. So once again, we're seeing a lot of repetition here. The final bill, Healthcare Prices Revealed and Information to Consumers Explained Transparency Act. So this act, among other things, would require insurance plans to publish the in-network and out-of-network charges for covered items and services and the negotiated prices for covered prescription drugs, again targeting transparency. All right, so what is next? These bills are simply proposals and have not yet been passed. The final PBM reform bill will likely contain components of many of these bills, but I suspect that transparency will be a critical component. Allowing regulators to take a closer look at the business practices of PBMs and insurance companies will likely be a critical step towards curbing their massive influence. Additionally, promoting competition within the industry is another powerful tool that will be critical in slowing rising drug prices. I don't know what the final bill will look like or when it will pass, but I'm hopeful to see some movement in this in the next year or so. Until then, all we can do is stay active in our local and national advocacy groups and continue advocating for our patients. Thank you guys for listening to my presentation. Here's my list of sources.
Thank you.
You guys have any questions?
Appreciate you. Dr. J, go ahead.
Hunter, very good presentation and definitely something that we really haven't covered. So I want to say thank you for touching on this topic. And there's a couple things here that I'd like to ask you relevant to those bills that are being proposed, yet none have been passed. So Of those 6 that you showed and shared with us, like one of the commonalities is the word transparency. And
Mhm.
with that comes an element of trust. So saying the word trust and transparency, which of those 6 bills do you feel represents the best advocacy for the patient?
It's a good question, and it's hard to answer that question because these bills are operating under the principle that spread pricing um, and steering and lack of transparency are the critical factors that are allowing these PBMs to behave in
Yeah.
their way. So it's hard to say because if I want to advocate for the bill that has the highest chance of being passed, I would advocate for the PBM Reform Act. That is a bill that has a forecast of over 50% of being passed. And so I think that would probably be the bill that I would put my advocacy efforts behind. Um, the truth is, the final legislation will likely have only one or two of these aspects. So I think transparency, any bill that can advocate for transparency and that advocates for study of these companies would be the best for patients.
Okay, so that's you've answered it, I think, in a very broad way.
Mm-hmm.
And to advocate for the patient, is this something that we can do at that level? Meaning, I understand there's other organizations that are involved for patient advocacy in this area, but how would you best encourage that advocacy? You know, you say get involved. We all get involved in local, regional, state, and national. But then, like you said, nothing's been passed yet. And the business keeps on going. So I'm not sure where the most effective way or what procedure would be the best implemented to have the most clout of advocacy. Because you're all in this, we're all in this to help offer quality patient care at a reasonable price for everyone to benefit. You know, and it's kind of a not to gouge and make mega dollars. And when you know that you've got to have your insulin or your medicine, and sometimes it's prohibitive. So I'm not sure where it is to be the best cheerleader for the patient.
Well, the truth of the matter is we need people in rooms talking to lawmakers and telling them this is a priority for doctors.
Yep.
One way to do this from a individual level is simply to call your representative and say, hey, I have interest in this bill and I would like to see positive motion on it. Of course, that done hundreds of times by local physicians would certainly have an impact on a local lawmaker. The reason I wrote this article was to set legislative priority for the AMA. My goal was to make this one of the top 3 policy topics for the what do they call it? For like the medical student Washington trip, um, in order to get the AMA officers talking to the legislators about this topic. Unfortunately, it didn't make the top 3, but that is an example of something that you could do in order to get these laws moving forward.
Well, I appreciate the explanation and that you speak with clarity. It's not mumble jumble. It's very straightforward. And I thought you took a very difficult topic with your slide, your diagram, your arrows or your paths, and explain how one gets their money and that goes to the next spot, etc. So I want to compliment you on that. Thought you did a
Thank you.
really good job. Thank you.
I appreciate that.
Student
bet.
Dr. Kramer, I have a couple of comments and a question. Having taught at KU School of Pharmacy for 17 years, I've heard a lot about this over the last couple of decades, and it's been controversial, especially in schools of pharmacy, pharmacy benefit managers. I liken it to farming, how it's progressed in this country, and I'll tell you the analogy I'm trying to make, and that is, it's called vertical integration. When, you know, these companies that like ADM, Supermarket to the World, own everything from the ground that the crops is grown on to the supermarket where the product is sold and everything in between. That's called vertical integration. And pharmacy benefit manager companies are part of health insurance companies as well as pharmacies. And there's a lot of so-called vertical integration in this game, in this gig, in the pharmacy benefit manager gig. And invariably, inevitably, the consumer ends up paying the price. And that's a common criticism of pharmacy benefit managers, is they don't pass on the savings that they are able to negotiate to the customer per se. So I wonder if you could comment on that analogy or that concern.
I like that analogy a lot. And it is truly the main concern with these companies is because they have all this leverage to negotiate drug discounts, but they pass maybe 1%, 2% to the customer and instead drive up prices. And I think a lot of this stems from the fact that this money is in a closed loop. It doesn't have to go anywhere. They're not competing with anybody except themselves. And so I think one way to address this would be to bring in some antitrust lawsuits and break up PBMs from the health insurance companies that operate them. And then at least those two companies will start to have to compete with each other for savings. But the truth is, it's gotten so big and so out of hand over the past couple of decades that this is going to take probably another decade or two to work out. But I think taking bite-sized pieces out of this problem over time will be extremely beneficial. But the size has allowed this to happen for sure.
And you know, another thing is that most patients don't know anything about this situation. They just kind of pay the bill. Dr. J, you had another comment. Go ahead.
Just to follow up on that, Hunter, what is your current, what's the pulse from pharmaceutical companies, manufacturers, distributors for compassionate care? And I say that based upon the need for the medicine in the sickest of patients, and some don't, some in our era, companies would yield in if your doctor wrote a letter or made a phone call. Do you have any thoughts relevant to pharmaceutical companies sensitive to compassionate care?
Yeah, I can't speak for all pharmaceutical manufacturers, but I have certainly read a number of articles from the perspective of the manufacturers. They say, they're upset with this arrangement too. And their response to it by increasing list prices is simply a result of this ridiculous pricing model that they're a victim to. A lot of these pharmaceutical companies offer, I don't know specifically what they call it, but they will allow patients of lower incomes to access the drugs at lower prices. So that is one way they're helping combat these prices. But the truth is, they're trapped in this economy the same way we all are. In fact, these drug manufacturers often offer different prices to different PBMs based on the rebates, because they have to, for example, raise prices for Express Scripts just to make a profit so they can keep their facilities open. But they're not doing it because necessarily they're evil, greedy companies.
Yeah, it's a tough dilemma, and unfortunately, the patients suffer more than they benefit. So,
Yeah, absolutely.
One more comment might be, you know what recently happened with insulin pricing? Congress and President stepped in. Is there any thought with executive action like that, or through Congress, in creating or expanding subsidies for enrollees who might select more generous forms of coverage in their plan?
Could you reword your question?
So there's a lot of problems perceived with pharmacy benefit managers, and one approach might be placing tighter minimum requirements on the levels of coverage that these insurance plans could offer. Just like Congress recently did, they kept the price of insulin, right?
Yeah.
So could something like that happen?
It is certainly an approach I've considered. I think a lot of the issue of PBMs comes from the practice of insurance companies trying to pay as little reimbursements as possible. So certainly increasing minimum standards for insurance companies could do a lot in solving this problem, but ultimately, I think they're slightly separate issues. But yeah, minimum standards for insurance companies would be an excellent step in helping prices in general for patients.
But did not the insulin repricing take an act of Congress, or was that an executive action?
I don't know off the top of my head.
Well, it's an interesting and vexing problem. And let me say this to you personally, and that is, you took a very complicated and vexing problem and distilled it down. And so that raises a question in my mind from me to you. How are you going to integrate this into your career trajectory moving forward? That's one question. Go ahead and answer that, and I'll formulate my other question.
Yeah, I have always, since I started medical school, I had to make a decision if I wanted to spend my time focusing on clinical research or advocacy. And maybe I didn't have to make that a choice, but I decided to spend my time focusing on advocacy. It's something that I've been interested in for a long time. I got involved with the AMA as soon as I could and have been working with legislative committees to help craft the medical student section agenda. And it's something that I think a single physician or medical student can do to make an impact on millions of lives. And I think legislative change can stand. The changes from legislative policy can last decades.
So is your compass headed towards DC after graduation then, you think?
I don't think I'm going to go full time on advocacy, but it's certainly going to be something that I'm always involved with throughout my career.
Last comment about your talk might be that this is a topic probably not a lot of med students, especially not first year rising second years, think about much. So what stimulated your interest in this topic per se, historically? Was there an experience or something you saw that spiked your interest?
Nothing that I can think of like a single incident. But when I was getting ready for the beginning of this legislative cycle with the AMA, I was researching healthcare policy and legal topics that I wanted to write about and bring to the medical students. And this is something that jumped out at me. I just found it immediately interesting. And as I started learning more about it, I realized that it was endlessly complicated. And so I wanted to create an article that made this simple for medical students.
Okay, you keep saying article. Is it published?
Unfortunately, it has not been published yet, but that is my goal.
Okay. I can publish it on the intranet if you have a publishable version that only KCU students could see. And, that's legit. It wouldn't discount your ability to publish it outside. That's something I'm offering.
I wouldn't mind that.
Okay.
That would be great. It's finished. It's a finished article.
Yeah, I can associate it with your link on MKRC Canvas.
Oh, excellent.
Moreover, let me offer my profuse apologies for being a little late, getting caught up in so many darn meetings at this university.
Next, Senator,
No worries.
would it be possible to share his slides, particularly relevant to how he broke it down into who pays who?
Yeah, I can associate your slides with the talk and then send you a link, Dr. J, as well as the article as well.
Yeah.
Student Dr. Kramer and I will work to make that happen.
Thank
The
you.
article also has that graphic in it, so either way, you'll be able to have access to that.
That's excellent. So this is being recorded. If you want, I'll include the discussion, but if you don't, I'll append it, and then post it on YouTube and send you a link in the next day or two, student Dr. Kramer, okay?
Hence the word.
Yeah, feel free to leave the. I'm sorry?
I say hence the word transparency.
Yeah.
Right.
Yeah, feel free to include the discussion.
Okay, will do. Thank you, everybody, for attending. This was the last one of the year. We obviously saved the best for last, right, Dr. Kramer, student Dr. Kramer?
Of course.
And we'll turn this on again next semester. Everybody have a great summer and see you next year.
Bye-bye.
Thank you.
Bye now.